So I have another deep anterior lamellar keratoplasty video today, but bear with me, this is slightly different from the previous ones. So this patient's had a intrastromal ring carried out previously elsewhere, and also has had corneal cross-linking previously. And the visual outcome wasn't as expected from before, and was struggling with vision, still having to depend on contact lenses which weren't fitting well, and the cornea was still irregular, and so we decided together to carry out a deep anterior lamellar keratoplasty. So here you could see me removing the intrastromal rings. It's not so essential that you take the rings out through the preformed tunnel. I did that with the first ring, I just pulled out with a Sinski, but here is being a bit more resistant, so I'll just cut the anterior stroma above the ring, being careful not to perforate the cornea. And now I'm just pulling out through that opening from the anterior stroma. Sometimes these can be a bit fiddly, so it's best to remove it as efficiently as quickly as possible. So here I'm marking my trefonation points. You want to go beyond the part of the intrastromal rings, and you want to make sure you cover the majority of the diseased cornea, in this case keratoconic cornea. And here I'm just using a ink pen just to mark the trefonation size. I'm using a crescent blade just to remove the irregular epithelium on the surface of the central cornea, just to make my view a bit better for later on. Just spraying the surface with a bit of BSS to make sure my view is adequate. And then I'm going to dry this area and then mark the center. It's important you mark the center because sometimes the center point is all you have when you put the trefine on. So you want to make sure the trefine is as central as possible, especially when you have made the size of the trefonation just enough to cover the diseased cornea. You don't want it to end up being beyond this point. So here you can see on the adjustable trefine, I've marked the vertical and horizontal meridians on the little notches. I've adjusted the trefine to give me a depth of 400 microns, and now I'm applying suction, and I've achieved suction successfully, and now I'm just trefining down the fixed depth. I find this trefine really easy to use. An adjustable trefine is also almost essential for me to use for these cases, as it removes another complication factor in terms of knowing how deep to trefine. Now I'm using the Sinski just to make sure the trefonation is complete, and having put a bit of BSS on the cornea to check my view again, I'm just making a paracentesis, just big enough to insert some gas, some air through a Rycroft cannula. So you just need to inject a little bit of gas, so a few bubbles into the AC, just to help you with the big bubble technique. Now I'm focusing down, and I'm using a bent orange needle dipped in some Gentian violet, just to make an entry point for the DALK cannula. So I'm just going halfway through, and then I've got ink mark of where I should go in. So here I'm using the DALK cannula attached to a 5mm syringe of air and wiggling it from the posterior edge. So you see that wiggle or that shake that I'm doing, that just helps open up the posterior stromal fibers. And you can see it's almost gliding through. There shouldn't be too much resistance. I'm going beyond the center point, and now I'm going to inject. So you can see the gentle injection, and now you can see the big bubble develop. That ring of white that develops tells you that you've successfully done a big bubble. So here you can see the regurgitation of the air. I'm just gently pulling the cannula out, putting some viscoelastic on the surface, and just slashing the anterior stroma. I'm injecting some viscoelastic into the pocket that's been created. So here you've got a pocket of air, which is now going to be replaced with viscoelastic, so that it maintains that distance between the anterior stroma and the Descemet's membrane below. Now, because of the previous history of a intrastromal ring, I didn't feel comfortable removing the anterior stroma directly, so I thought I'd remove the residual stroma, or the cap, with a crescent blade first before making my quadrant removals. So I've got a little bit of time now to talk about things to remember when you're doing a DALK. So first thing is you don't necessarily need a Floringa ring with these cases. You've got the structural integrity there already if you get a successful deep dissection and retain the posterior fibre and the Descemet's membrane. The other thing is, I've had the question of whether you should leave the intrastromal rings in when you're doing the big bubble. My personal preference is to remove the rings before doing this, but be very careful not to perforate the cornea when you're doing this, as I've shown in the beginning. The other question is whether it's more difficult to do deep anterior lamellar keratoplasty in patients who've had corneal cross-linking. Now, in my experience, I find the suturing actually easier in patients who've had previous cross-linking. The initial Trefline feels more crisp, but with cross-linking patients, the usual depth of cross-linking is usually around 300 microns, and you're usually going deeper than that when you're doing a deep anterior lamellar keratoplasty. So in my experience, I don't think when you're dissecting the posterior stroma, it makes much difference with a patient who's had previous cross-linking. But with anterior stroma, the behavior is slightly different, and when you're suturing in, the behavior of the cornea is slightly different as well. It's not as stretchy or elastic. So this is good in a way because it creates quite a stiff sidewall to suture into with the corneal graft. So I'm just finishing off the removal of the anterior stromal cap, being very careful not to go beyond the margins of the trefonation. It's important with a sharp blade such as the crescent knife not to create separate dissections, and try and make sure you stay within the boundaries of the trefonation. So here I'm using my guarded DALK scissors to open up the pocket. So I want to create 4 quadrants if possible. Sometimes you may need to create more cuts. So here I'm creating my first quadrant. You can see that the anterior chamber is still well maintained, and the AC is still full of the gas bubbles underneath. So here I'm just opening up the quadrant using a pair of calibris just to lift the quadrant up, and try your best to cut the stroma up against the wall of the trephine. Try and leave as little residual tissue as possible. You can see that amazingly clear Descemet's membrane underneath, which is maintaining that air bubble. So now I'm just cutting the second quadrant, being very careful not to drag the Descemet's underneath. And this is different from my previous videos. This DALK big bubble was extended beyond the trefonation points, and therefore it made it much easier for me to remove the residual anterior stroma up to the edge of the trefonation point. So here I'm creating my final quadrant, and I'm not using calibris this time because I felt there was enough space in between to put my DALK scissors through. And you can see the DALK scissors are very blunt on the bottom half. They're almost rounded, so they don't create any risk of dragging or catching of the Descemet's membrane underneath. This is helped by the fact that there is viscoelastic, allowing the scissors to glide over the Descemet's. I'm trying to make the opening as clear as possible and as free from any stromal fibers as possible, so I'm just cutting the residual stroma here. Now I'm doing the final quadrant. Now again, be very careful with this final quadrant because the rest of the Descemet's is exposed now. There's nothing securing the superior part of the Descemet's. So this final quadrant is the most challenging part actually. So that's why I left a little bit of stroma to trim later on. So here I'm just grabbing the loose edge with the calibri and just holding onto it while I'm just cutting all the way around to create that nice clean walled edge. Again, being very careful not to create too much tension on the Descemet's underneath. I'm just trimming the remaining bits. And now what I do, just before that point, I'd usually wash off the viscoelastic on the Descemet's bed. I've removed the Descemet's membrane from the donor cornea and done the trefonation, and now I'm placing it onto the cornea. Now I'm using Pollock forceps initially to do the first part of the cornea, but when I move on to the host, I sometimes flip over to a Calibri. It just makes it slightly easier to pinpoint exactly where I'm going to place the suture. So I'm just trying to go as deep as possible, but not catching the membrane. It's really important you ensure that cardinal sutures are as parallel and as adequate attention as possible. Now the reason why I'm mentioning this in this video is because I did things slightly different with this video. You've noticed with the first cardinal suture I haven't tied it completely, I've just done 2 throws, and now I'm doing my second cardinal suture. This is because I want to put my second cardinal suture in and then adjust the tension for the first one to make sure I start off with the proper tension on the graft. So now I'm just tying my second cardinal suture, trying to judge how tight I should do it based on how the cornea is behaving. And I'm looking at the tension created between the untied suture and the one I'm tying now. So here I'm just doing the full 4 throws, trying not to over tighten, and now I'm going back to the first suture, first cardinal, and I'm tightening that again. So this has not been completed, I'm completing it now. So this gives you that vertical line that you're seeing, dividing the cornea into half, and it allows me to adjust the tension a bit more than just tying the first stitch first and then doing the second stitch. So now I'm doing my final 2 cardinals, and again I'm trying to achieve that diamond shape that you should get after putting your cardinal sutures in. So here I'm being very careful not to touch the posterior stroma or the Descemet's, pulling it through. And you see how the air bubbles are maintaining their position within the anterior chamber. If you saw bubbles coming out through the Descemet's, then you know that there is a potential leak or a potential perforation. So here I'm just doing my final cardinal suture and making sure the tension is as adequate as possible. I'm trying to make the sutures as equal to each other as possible, but it's sometimes quite challenging when you're doing the cardinals because you're working with a graft that's moving around a little bit. It's not secure onto anything. So here I'm adjusting the tension. I'm trying to look for the diamond. I'm trying to look for the behavior of the 9 o'clock and the 6 o'clock sutures. If they're being dragged over too much, you know that that cardinal is too tight. I usually use a 15 blade to trim the sutures to allow more accuracy. And now I'm using the spear just to dry the edges, removing any residual viscoelastic and exposing that diamond. And now I'm using a star marker just to mark the remaining marking points for the sutures. Now I've cut the video a lot because I've shown you plenty of videos of me suturing, but this is just to show how I'm trying to be as accurate as possible with placement of sutures. So I'm using the edge of the diamond and the edge of the marking point from the trephine to use as a guide for my sutures. So you see I'm trying to make everything as equal and as regular as possible. I'm trying not to come out beyond the limbus to minimize any risk of bleeding. I'm trying to be very careful when I go through the donor cornea and down into the host cornea. Now I'm just tightening all the sutures now. Again, I'm not going to show you tightening all the sutures, I'm just going to show you clips of this, and just as an overview of the fundamentals of doing suturing for DALKs. I do sometimes do continuous sutures for DALKs after having done a interrupted, but again it varies depending on the type of graft I'm doing and also on the patient as well and the aftercare that's required. Now you don't want to use any viscoelastic on the ocular surface while suturing the DALK. You don't want any viscoelastic to get trapped in the gap between the donor and the host. So I tend to ask my assistant to just keep the donor graft as moist as possible. Now here, I'm zooming into this suture because I think this was the point when I managed to get a tiny little perforation on the desmos. So when I completed the sutures, I decided that then to put a little bit of an air bubble inside the AC just to maintain the apposition of the desmos with the host, with the donor cornea. This is important to do when you're suspecting but not confirmed a slight perforation of the desmos. Now, microperforations or minimal tears shouldn't pose a problem, but you don't want to end up with a double AC later on. So if you put a tiny amount of an air bubble, maybe 50%, this should be enough, especially with the location of the suspected tear, to hold the desmos in place while the patient's recovering. Now I'm tying the remaining sutures, just finishing off the 16 sutures that I'm placing in. And I'm making sure the tension is as equal as possible amongst all the sutures so you don't get any excessive tension on one side compared to the other. Now my tendency for DALK cases is to over tighten the sutures because I want this graft to push into the host bed and not for it to protrude outwards. So I have a tendency to cause flattening of the cornea after the deep anterior lamellar keratoplasty while the sutures are in, and when the sutures come out, the patient tends to get a steepening of the cornea from the initial flattening, which tends to give a good visual outcome. But during the recovery phase, before the sutures are removed, the cornea tends to be slightly flat, so the patient tends to have a slight hypermetropic shift. I'm trying to move away from this practice, so I'm trying to suture at a normal tension rather than over tighten nowadays. But in this case, I have over tightened a little bit to make the cornea as flat as possible to push it into the space that's created. Now I've finished the sutures, just trimming them with a 15 blade, and now you can see I'm injecting some gas into the anterior chamber just to push the remaining decimase superiorly. And while that's happening, I'm doing my another suture just to trap that cornea in place, because I put a little paracentis suture in as well. And you can see the eye's under a little bit of tension, so you need to release some of this gas afterwards. So while you're tying your last suture and while you're rotating the sutures in place, you can keep the gas at this tension while that's happening, and that allows for the decimase to oppose up to the donor cornea a bit better. And here you can see I'm just rotating the knots into position. I vary again. I tend to use a knot, leave the knots either on the host or the cornea, but never in the junction. And I'm just using my cannula just to make sure there's no other perforations evident. And I've now released some of the gas. So this is a bit of subconj Keffen bet.